Chairman, colleagues and friends, thank you for inviting me and giving me the chance to participate in this great meeting. Also, it's a hard burden to talk after this guy in front, which I had the chance to meet last summer in his institution, which impressed me a lot. Now my job today is not to talk about this crosslink that you are doing every day, which has been accepted all over the world. Meanwhile, I should now give you a few hints how things are going on. Now, the first information or hint is, remember that we started with this standard volume type cross-linking that we added 0.1% or 0.05% riboflavin for 30 minutes and then embedded it, the cornea made it totally yellow, and then added the ultraviolet. Now, this is past. We do have also a surface type of cross-linking, which is used just to have a very high concentrated riboflavin solution for a short period of time, which is localized then, because the concentration and the localization of the riboflavin is responsible for the gradient of radicals to be produced and the area of cross-linking. So if we then have such a distribution and add our 3 milliwatt per square centimeter ultraviolet, then we get a relatively deep cross-linking effect, a volume type cross-linking, 250 microns up to 300 microns deep. If we add a very high intensity or a higher intensity ultraviolet for a shorter period of time, the same dose but only shorter, which leaves the riboflavin in place during that time for 6 minutes or for 9 minutes, then you get a very localized cross-linking effect. So now, let me share this patient with you. This is a 24-year-old male, wants to have LASIK for -3 diopters, and if you look at the axial distribution, it doesn't look bad at all. It's not really suspicious, but if you look at the thickness chart, may I draw your attention to the D-center thinnest point, and then the difference between up and down, so superior and inferior, is more than 50 microns. This is something where you shouldn't do a LASIK, being honest. That looks suspicious, especially if you look then, which is not included here, the posterior elevation, the float is 18 microns. So that is a borderline case where you should do something else than LASIK. And many of us are doing in those cases just a topography guided or even here wavefront optimized PRK, a surface ablation, but I know countries where PRK is not well accepted. In Arabic countries, the incidence after PRK of scarring is 7 times higher than in Switzerland, and so I understand that those guys rather would like to do a kind of LASIK. Now that's the question, why don't we do a LASIK with a thin flap and add that immediate surface type of cross-linking right away? And that's why we started in Zurich last year a prospective study in patients with a preoperative keratectasia score, the score of Randleman, with 3+. So those are patients that have to be considered as risky LASIK patients. And we did a superficial cross-linking, created that pseudo-Bowman, I will show you in a second, a rapid cross-linking. That means that it's very localized, a higher power, 10 milliwatt per square centimeter for 6 minutes, and a high riboflavin concentration in the interface under flap for 2 minutes. 1 month after, you can easily see in OCT that you do have a pseudo-Bowman's. You do have created a very localized cross-linking layer, and we know that we do have a more than 4-fold increase in biomechanical stiffness in that pseudo-Bowman's layer. You can also see it at the slit limb. There is some haze, We do have DLK during the first 3 days after surgery, and in the small slit you can see that it's localized really nicely in the interface, that haze. It disappears within 3 months, as usual. But there are also problems involved. First of all, this DLK stuff, which is there in nearly every case. If you compare the visual increase over time and compare the rapid cross-linked eyes together with the standard, you can see that there is a significantly delayed recovery of visual acuity after this rapid cross-linked LASIK cases. And the worst experience was when I did a reoperation at the 3-month follow-up, which is done easily. You do a relift within a minute and add another half of a diopter of over or under correction. Tell you, I couldn't lift that flap anymore. I had a half an hour. I worked hard to lift that flap, and I didn't accomplish it. I gave up after all. You cannot lift those flaps anymore, because obviously due to that cross-linking effect, you create new layers or connections between the flap and the underlying wound, which of course provides better biomechanics afterwards. So as conclusion number 1 in this topic is distinguish in the future between volume and surface cross-linking. These are different approaches. And rapid cross-linking during lacing is a viable option with also significant side effects. So you don't get anything for free in medicine. You have to sacrifice something in order to get more safety. You get a longer DLK, you have a delayed visual recovery, and you have this adherence effect, which has also side effects in terms of not being able to do a relift anymore. Let's come to the second point. This is a number of points that I have to cover today. This is a patient coming in with that terrible corneal topography. You say, oh God, what is that? This is the slit lamp photography. And now it's easier to make that diagnosis. What is it? Maybe something that you don't see here in this country, but we see it not frequently, but I'm seeing it, say, twice a year. This is a morbus terrier, and in English pronounced as Terrien's disease, as the Americans continue to ignore French. So here we have it, and you can easily see that also, that thinning disorder in the upper periphery in the pentacam picture. Compare this to that. Now, in such a case, we don't have so far a good therapeutic approach. We did this crescent when I was a young super assistant in Berlin. We did this crescent keratoplasty, which never worked. Were a lot of work, but was successful. But those thinning of the peripheral cornea is not an isolated disease. You can see that very often. In advanced cases of pellucid marginal degeneration, you have that's where the name is coming from, a marginal degeneration, very thinning in the periphery. Morbus terrier, in Moorland's ulcus, of course you see it with a sharp edge in contrast to morbus terrier. In some cases of Sjögren syndrome, and of course in peripheral infections, keratitis, you see that thinning, which can continue even after the infection. And the goal of cross-linking in those applications is, of course, to stop that thinning process. And it was very nice of Gregor Wollensacker, a former co-worker of mine, he did a nice experiment. He cut 10 millimeter PIC cornea buttons and put it in a solution of pepsin and collagenase, and saw how fast those buttons were eaten up. And the standard was done in 6 weeks. In 6 days, the whole cornea was eaten up. If you do only minor cross-linking, that doesn't change. But once you accomplish our clinically significant and evaluated cross-linking of that cornea, then the eating up time, so the resistance of the collagen, is increased by a factor of 2. So you can change the collagen and make it more resistant to the digesting enzymes, which play a certain role in the thinning and the melting process. How is it normal in this extracellular matrix? Remember that we do have a synthesis which is made by keratinocytes, and the same keratinocytes that synthesize the collagen at her backside are eating it in the front side. They are doing a catalysis. And in your and my cornea, this synthesis and catalysis is in an equilibrium. They're eating up as much as they are producing new collagen. And in those guys where we have a thinning, a melting process, the catalysis is stronger than the synthesis, and therefore you get this slowly thinning, which you cannot stop up to now. Here comes cross-linking into place. On a sudden, you can reduce the activity of the enzymes, and therefore you can shift that equilibrium from the catalysis side now back to the synthesis side. And that's exactly what we saw in this case of Morbisteria. Those images are 1 year apart, and indeed we could reverse Morbisteria. We could accomplish an augmentation of the thinning of the superior cornea. And this is, to my best knowledge, the first therapy that makes sense in Morbisteria. This is, by the way, the topography. You see, they are 2 years apart, I think. You see the difference. We do, due to the augmentation, the cornea was not steep here anymore. It flattened down, and the best corrected visual acuity by spectacles improved from 2050 to 2030. He is now capable to use contact lenses again, and does his work as a medical artist again. So the crosslinking of the peripheral cornea, how do we do this? You have to have a wide area because you want to go out to the limbus to do the cross-linking, but therefore you have to protect the epithelial stem cells, because we learned from Dr. Prema from Chennai, by the way, that even in the standard cross-linking process, we are killing 11% of the stem cells. Hey, 11% of the stem cells. So we will have to protect them anyway, and this can be done by rings like that, made by paper, or produced by yourself, or you use these old Marisol rings, which were produced for LASIK in the old days. The majority of the characterization cases have the weakest point in the cornea that needs cross-linking 1 to 3 millimeter away from the center. So it is, even in the normal keratoconus cases, you don't need to treat the center of the cornea. You need to treat more the periphery, not the far periphery, like in the cases before. And therefore, and you can see this easily at the 1 month follow-up after standard cross-linking, that demarcation line falls off from center to periphery significantly. We did internized measurements about this at 1 month after cross-linking, and you can see that from the central cross-linking depth, it falls off by, on average, by 35% towards 3 millimeters away from the center. So we are losing a lot of the cross-linking effect in the majority of the cases, although we want not to treat the center of the cornea. We would like to treat the mid-periphery or even far periphery. And therefore we designed at IROC, and so a top-hat profile is just not good enough. And therefore we need to increase the intensity of the light in the mid-periphery by at least 25%. There's where my financial interest comes in. You know that I'm one of the founders of IROC, and this is our ultraviolet light that we provided 7 years ago, and this is what we believe is the right way to get an ultraviolet profile light, and this is what Avedro offers right now at the market. We believe that this is the way how the ultraviolet light distribution should look like for future applications. And that's exactly what we see here. Now here the demarcation line is approximately the same all over the place. It's not falling off towards the periphery. Conclusion number 2, and I have still 5 minutes to go. Cross-linking can stop corneal melting. And to create homogeneous cross-linking over the whole area of interest, we need an increased intensity profile in the periphery. Therefore, in the majority of the cases in the future, we will have to protect the epithelium stem cells. Now, let's come to my last topic, 4 minutes and 50. Why the hell do we still remove the epithelium? Can't we do a transepithelial cross-linking? And remember that 2 years ago, Riculin TE, transepithelial, was heralded as the way to achieve that procedure, transepithelial cross-linking. And early clinical reports from Mrs. Ertan from Turkey and Mr. Pinelli from Dr. Pinelli from Italy, they proved clinically this effect that transepithelial cross-linking would work. And the nice thing is, at the Milano meeting of the cross-linking in January last year, many Italian groups showed histologically that there was only minimal side effects. And then Dr. Sperl from Dresden came up and presented his experimental data, and he saw that this is a control biomechanical effect in kilopascal control, and this is the standard cross-linking. And then he used the Riculin TE in rabbit and pig corneas, and the Riculin with 0.1% and benzalkonium chloride, and you can see there's nearly no effect. Of course, then we didn't have side effects because there was no main effect, and that's where we are standing today with the transepithelial approach still. Wollensack again has also demonstrated that the biomechanic effect is only 20% of the standard procedure. And then Sperl started to do more biomechanical experiments. We asked him to do that, and we helped him also to do that. So we used 0.2 because we believed that benzalkonium chloride, as the dry eye guys before complained about this, now we would use it to open those gap junctions, so leaving the ribon penetrate through the epithelium, and indeed it works. If you use a benzalkonium chloride for only a few minutes, 0.2%, and then add the riboflavin, it works nicely. Even better with 0.04% benzalkonium chloride. However, benzalkonium chloride at a concentration of 0.02 produces significant healing defects. After treatment after treatment with 0.02% benzalkonium chloride, the epithelium would not heal anymore for days and weeks. Now they changed the issue and did use now again the 0.01% benzalkonium chloride and added different osmolarities, and see there are some formulations, chemical formulations, that help to come close to the standard cross-linking effect, even with an intact epithelium. But such drops are still not on the market. Yes, we believe that transepithelial cross-linking will come. We still have to work very hard to find out the optimal pharmacological formulation of those drops, and it will include some enzymes, it will include hypoosmotic solutions and some kind of benzalkonium chloride, but it's not yet found. And now comes my question for you, and I'm asking you intensely not to use any non-confirmed drops. Don't use your patients as guinea pigs for new approaches that have not been proven scientifically in the laboratory. Thank you very much indeed for your attention.